everyone. Welcome. It's great to be here with you all. As we think about planetary health in North America, there's some wonderful signs of movement from awareness to action, especially within healthcare. But again, as I said in my previous session, progress is a bit uneven and there's still some gap between what we know and what is being implemented at scale. In many places, sustainability is still treated as a side initiative rather than something fully integrated into how we deliver care, improve operations, and prepare for the health impacts of a changing climate. And that's really the tension that we're sort of sitting with. So this panel is an opportunity to explore what it actually looks like to move this work forward in practice across both hospital and outpatient settings and within real-world constraints. We have a group of leaders here who are actively doing this work, and I'm looking forward to hearing not just what they're doing, but how they're navigating complexity, barriers, and competing priorities to make progress. So with that, we'll get started, and I'll introduce each panelist in turn. We'll hear from each panelist, and then we'll finish with a Q&A. So please prepare your questions as we're listening in and hearing from our speakers. So first we have Dr. Heather Baid, who is an intensive care nurse and associate teaching professor at the University of Victoria, Canada. Heather has experience with research, quality improvement, and education in patient care. Recently, Heather led the National Intensive Care Environmental Sustainability Recipe Book project in the United Kingdom, which provides guidance for intensive care units on how to lower their carbon footprint. She also leads organizing the annual SHARE conference, which is Sustainable Healthcare Academic Research and Enterprise. And I will hand it over to you, Heather, and feel free to start sharing your screen if you'd like.
Thank you very much for the introduction and the opportunity to speak today. So thank you so much, Joe, for the introduction. I am now based in the University of Victoria, and so I'm coming today virtually from the unceded territory of the Lekwungen and Wasanich peoples. And I do originally come from Canada, but I've been living in England for the past 25 years up until very recently, a few months ago, started a new job here in Victoria. So I'm going to be sharing experiences from England and look forward to hearing the other speakers as well today and this discussion. So my aims were to explore strategies to address climate, pollution, and biodiversity threats to acute and outpatient settings. I'm going to mainly focus on the project that Joe mentioned called the Intensive Care Environmental Sustainability Recipe Book, but I thought I would share some other resources related to nursing and midwifery that promotes the health of people on the planet in the session's themes today. So we were just hearing in the other session about the triple planetary crisis in relation to climate change, biodiversity loss, pollution. This whole conference has been a really fantastic way to just learn more about these themes in relation to how they are relevant to us as nurses and midwives and other healthcare professionals. And we know that these planetary health issues are intrinsically linked with social justice issues. Cumulatively, that cause more public health issues. People get sicker, they need more health care. We create a further environmental footprint, and around and around we go in this sort of vicious cycle of the links between planetary health and healthcare delivery. And as I said, I was drawing from my experiences in England, and there is a national strategy in England. And it's also embedded into the Health and Care Act, which is quite unusual for a country to have legislated this. So this does mean that there is very much top-down policy in terms of statutory legislation that all healthcare organizations are required to reduce their carbon footprint. But Joe, I was interested when you were talking about systems change and cultural change. So my experience in England is, yeah, we've got this fantastic top-down stuff, but every time I teach this, nobody knows about it. So how do we make that authentic systems change where it becomes part of our day-to-day being and not just something that's, you know, kind of out there, which is great to have, but we need to bring the we need to operationalize that top-down strategy and to be using this in our day-to-day nursing practice. And this carbon footprinting was from the most recent data that was refreshed last year for NHS England as a whole for the healthcare service. And what's really striking in these types of carbon footprinting exercises is just how much clinical work is really relevant. So of course, energy in buildings and estates and all of that type of thing is important. But if you look at just the carbon footprint of medicines and prescribing coming out as the top piece of the pie, other parts of the supply chain, medical equipment, that's the stuff that we use day to day as nurses, and nurses and midwives creating such a huge proportion of the workforce. And so what a role and what an opportunity we have as nurses in order to make a difference at reducing the environmental damage that healthcare causes. And just before I get into some specific examples of how I've been involved in that, I always like to do this kind of slide at the beginning of my talks around really ultimately this is about improving patient care. And with any sustainability work, I've just come from an ethics journal club where they were talking about exactly this. What about the ethical dilemmas of tensions between trying to not cut corners because of financial costs and the planetary health demands and things. And I brought up the point around actually, can we start this from the lens of quality care? If we do what's better for the patients, quite often that's also better for the planet. And then we have these financial, environmental, and social co-benefits, but really looking at sustainability as being quality improvement. So this national project in the UK was a collaboration between the Intensive Care Society, which began this work, and they collaborated with the Faculty of Intensive Care Medicine, UK Critical Care Nursing Alliance, and the University of Brighton, where I worked at the time. And it was a big national project to try to do that cultural change and systems change that Joe was talking about, specifically within the intensive care community. Just to acknowledge the funders, we're very fortunate to get a nice grant from SBR Healthcare and the Green NHS. So it was a funded project, which meant we could do a really robust starting point and project delivery. So the project team included representatives from each of the partner organizations, and we had an advisory group of multidisciplinary professionals from across the UK. We did staff focus groups. We talked to former patients and family members to get service user perspective. And the grant also paid for a research fellow, just to acknowledge Pat Castro-Coelho's work. And she undertook procurement review, looked at policy and guidelines, observed clinical practice, evaluated waste and linen, and worked with the Centre for Sustainable Healthcare to do some carbon footprinting. So I know we're short on time today, so I'm just going to give some highlights of this project and the outcome that we produced. And these pictures are from that work. Just, intensive care is clearly going to be a place where we use a lot of stuff and a lot of packaging. So not surprisingly, the evaluation showed that there was just a lot of unused products that weren't even being used, because you open up kits and there's waste from the way that products are bought, but we don't necessarily have or feel like we have control over that as clinicians, and packaging waste. And just the daily amount of waste that ended up being quite a significant amount. I think the top patient was something like 32 kilos per patient per 24 hours, averaging about 10 kilograms per patient per 24 hours for an intensive care patient. So a lot of waste. And the other thing that came out was just how poorly waste was segregated. So lots of room for improvement around putting the right things in the right bin so that we're not paying to basically burn unnecessary items. So we use the sort of 4 principles of sustainable clinical practice around prevention, patient empowerment, lean service delivery, and low carbon alternatives. And we built this recipe book. So rather than calling it a checklist or a protocol or a pathway, we thought everybody's got too many checklists. It's essentially a checklist, but we just called it a recipe book to make it a bit more enticing. And just like you'd have recipes, if you were cooking in the kitchen, you'd have your ingredients and you'd have your methods. So the recipe book is around the format, and we use those 4 themes, as well as we kind of bookended it with first theme of teamwork and then some education, quality improvement research at the end. And we built 20 recipes organized amongst those 6 themes. I'll put the links in the chat afterwards if anybody wants to download it. It's freely available. Very welcome to use it. It's very much based on the UK context. So for example, I know the font's quite small to read here, but just to give you a little bit of an overview of what it looks like, each recipe has a list of ingredients and the methods and then a case study. And so all of the links and the hyperlinks you can see throughout, they're all of the UK, England, Scotland, Northern Ireland, and Wales resources that we should be using, things like waste management, infection prevention, etc. So this was the intention to, draw together these types of resources, like gloves off resources that were already existing, but this is one example of the links that are in there, and to create a recipe book that's easily digestible, no pun intended on the food thing, And to take something that's policy and actually say, well, we're all busy. What's something quick, easy, fast that we can use at the bid space to move forward on becoming more environmentally friendly in our care? Just a few thoughts on service user perspective. This was a real eye opener, having conversations with patients and families, and to really encourage anybody doing projects in this area to engage service users from the outset. And so I remember one of our initial meetings, the patient representative was really confused when we were talking about gloves. And he said he had never seen a nurse not wear gloves. And we all went, oh, okay. And then we had a conversation around actually, sometimes less is more and good hand hygiene. Of course, we wear gloves when we need to. Had a really good conversations around it. He said, oh, I'd never thought of that before. So the Royal College of Nurses has a flyer you can see here around, communicating with patients and families. Because what was a really eye-opening experience was we were, doing all this great work and producing all this, fantastic stuff going on. But actually, are we communicating this a way that makes sense to patients and families? And do they have fears around maybe things like people not wearing gloves the same way, or hearing about environmental sustainability? Equally, what came out of the service user interviews was people feel really concerned about the earth. And if you're environmentally sustainable and worried about the planetary health in your home life, and then you become a patient, just how guilty they felt about plastics and waste, et cetera, and things. So it was really productive conversations around how can we collaborate and co-design things together. And so we created this flyer, which is downloadable as well from the Intensive Care Society's website around the first line is caring for our patients. So that's that, care is quality care as being the top important thing. But by the way, we also care about the planet. I've got several more slides here, and I'm conscious of time and the other presenters. So what I'm going to do is just whiz through them as a sort of display, and I'm going to put the links in the chat just to show you all of the work that's going on in the UK around different challenges, just how much money is being saved by some of these very specific examples. I've talked to the ICU one, but I've gone through nursing, midwifery, emergency care, surgery. And I found this outpatient article just to finish, because I've never worked in outpatients, but I saw this session theme today and I had a quick look and found this lovely article really emphasizing, simple things we can all do. And a lot of these things, they're not specialty specific. They're, key principles that wherever you work in nursing and midwifery or any kind of healthcare around just good practices of stewardship. So in summary, I've talked a lot today about mitigation, but just to acknowledge adaptation is also really important. And the Greener NHS and the NHS England websites have a wealth of resources. I know a lot of the people, I noticed in the European section yesterday, I was speaking to some of these, but I'll put the web links in there because there's a huge amount of resources that have been developing over the years from their experiences there. So I'd love to hear from people. I'll put my email in the chat as well. And thank you very much for the opportunity to speak. Thank you.
Wonderful. Thank you so much, Heather, for your remarks, and what a wonderful presentation and a great reminder to engage the service users as we're developing these resources. Next, we'll hear from Kamala Simkhada, who is a Baltimore, Maryland-based registered nurse, who is soon to graduate with a Doctor of Nursing Practice degree in Health Innovation and Leadership from the University of Minnesota. Her doctoral work focuses on enhancing shared values of planetary health among senior executive leaders of an academic health system in rural North Carolina, using mindfulness practices to catalyze leadership and cultural transformation for meaningful and sustained climate action. She works as a senior research nurse at the Johns Hopkins University School of Medicine, where she supports national and international clinical studies and quality improvement projects in the pediatric anesthesia and critical care department. Her notable contributions include investigating sources and impacts of chemical exposures in neonates and children admitted to intensive care units, and supporting quality improvement initiatives to reduce carbon footprint in perioperative environments. And I'll hand it over to you.
Thank you, Joe. Thank you, Heather. That was very insightful talk. And it looks like you had so much things done already, whereas I'll share our story from the United States. So hi, everyone. I am currently in Baltimore, Maryland, and this was my doctoral project for my DMP program. the aim was to enhance shared values of planetary health among senior executive leaders of an academic health system using mindfulness meditation. So the community partner is ECU Health in North Carolina. So we all know that healthcare system is harming our planet. 8.5% is of national carbon emission is a lot, and we must do something to drop this number. Academic healthcare systems are uniquely positioned to take lead, but many have been very slow to take meaningful action. At Issue Health in North Carolina, I partnered with them in 2025, and at that time, despite being affected by extreme climate events every year for the past 7 years, they did not have a systemic dedicated leadership or working group committed to for this work. And they quoted there are competing priorities, limited funding, and whatnot. So in February of 2025, ECU Health was invited to join a cohort of 18 other academic health systems under American Academy of Medical Colleges to initiate their benchmarking sustainability metrics to benchmark the sustainability metrics. And acting chief experience officer, who's also my preceptor for this project, was asked to take the lead. So the CEO expressed that planetary health was so foreign to them, and then they are not ready to, they're not ready culturally or structurally to transition to this bigger scope of practice. And then we all know that sustainability can accelerate and sustain when it's driven by core organizational and leadership values and not just by some simple financial incentives. And this is why this project was born, to cultivate that very value-based mindset among senior executive leaders, so that they would prioritize a planetary stewardship and actually to have planet at the center of all decision-making table. So the purpose of this project was to enhance a culture of environmental stewardship among senior executive leaders at ECU Health by deepening their understanding of interconnectedness between human health, environmental well-being, and ecosystem vitality. Our specific aims were to reduce, not reduce, were to have at least 60% of executive leaders of the HS and to express that their understanding of interconnectedness with nature has increased after completing the mindfulness-based meditation interventions, and to also have increased commitment for incorporating planetary health targets within their organizational strategy goals. So mindfulness and meditation is getting very popular these days. Mindfulness is non-judgmental awareness of bodily sensations, thoughts, and emotions as they occur in the present moment. Meditation, whereas, is more formal. It's a systemic process of training the mind at sustaining attention on a particular object, or such as breath, emotion, visualization. This mindfulness-based interventions have worked in various settings. However, application among these stakeholders is unique to this project. Evidence shows that mindfulness meditation enhances environmental awareness, empathy, pro-environmental behaviors, raises greater environmental concern, and fosters sustainable behaviors by recognizing our interdependence on nature. So this project was guided by Cutter's 8-step change model. This is a very popular change management framework for initiating cultural transformation across various industries. I selected this model because it helps to systematically build motivation, cohesion, and ownership at leadership level, while ensuring that change become part of the organization's core value and practices. So for methods, we invited 10 senior executive leaders of that academic health system. We did pre-intervention leadership assessment. Oh, yes, we had so many questions to assess readiness for change, and baseline questions, other baseline questions. On a very important note, we used some senior executive leaders to lead the meditation sessions, and we made the sessions virtual and brief, about 8 minutes. We had 3 sessions. One of them is still being executed. I wrote the script. The communication marketing team produced it into a video. And then this is the pre-intervention survey result. This is a nature relatedness score. It's a validated score, nature connectedness score by Nisbet and others. So out of 100, 61 responded to the survey, and majority had medium score, and only 10 showed high nature connectedness score, and this indicated that we had some opportunity to work. So we asked if they see that creating healthy environment is part of their organizational mission, to which 89% is leaders responded yes. But on the following question, asking a following question that asked, would you recommend adding targets to sustain healthy environment or planetary friend targets in your organizational strategic goal? There was a 50-50 divide. This is what we wanted to change, this 45% number. And healthy environment is just a local lexicon they selected to use to represent planetary health. So this is post-intervention result. After completing mindfulness meditation, we sent the survey via email, and then number of participation varied for each meditation. So at least 86% say that they would recommend adding planetary health targets to upcoming organizational strategic goal after finishing the mindfulness meditations. And then 69 to 76% is leaders who did this session said that it was helpful in increasing their sense of connectedness with nature. And this is qualitative themes we derived from feedbacks after each session. Leaders' experience were within themes of restorative calm, presence, and compassionate awareness, interconnectedness with nature, and personal responsibility for small environmental actions. So as a doctoral student who was outsider to the organization, I got to witness what had changed since last year. Meditation sessions were distributed to C-suite leaders in November and December of 2025, and one is yet to be distributed. And the outcomes have surpassed what we have intended with our quantitative aims. The session was so appreciated by the system, and they are now being distributed to the entire health system for a larger system-wide planetary health awareness. Our intervention was heart-centered, cultivating planetary health values among leaders. So unlike at other institutions, we didn't start by focusing on the financial return upfront. And the main strategy that helped, I think, was connecting the intervention with their values, mission and values, which is to take care of the health of the Eastern North Carolina community, well-being of their community. And the effects are now trickling down. New initiatives and proposals are getting approved with no pushbacks, and I think that's a big win. These are some of the new initiatives that are happening. We're launching educational modules for planetary health for the entire healthcare system, and Joe was the one to frame this model, to build this module. And they continue to partner with Practice Green Health to work towards decreasing their carbon footprints. So far, they only had a voluntary healthy environments committee to discuss ideas. Now they are hiring 4 full-time experts to shape it into a formal department to lead strategically moving forward. And they have established a contract with local farmers to have all of their food sourced locally, which is huge. They also partner with Sodexo for reducing food waste. Their cafeterias are adapting to become hugely plant forward. And Earth Day, they are celebrating their commitment for planetary health and by planting trees around their employee well-being garden. And this is basically to mark their commitment to planetary health and to engage and educate about planetary health in their community or their health system. And I think this is just a beginning. It is going to be an easier transition now to focus on strategic goals and broader actions in years to come, I think. Limitations are subjective bias of respondents. We don't have a control comparison group, and we are also unable to establish causation. In conclusion, I think the project was impactful. Mindfulness-based project helped to lay groundwork for system-level awareness and engagement for planetary health, and initiate leadership buy-in and culture transformation for broader sustainability actions. Connecting rationale for the change to the mission and vision of the organization, using leaders to set the example, helped easy buy-in for intervention and set the stage for long-term actions. The project also provides preliminary evidence to adapt and scale at other institutions. Here's my references. And I would like to thank my project advisor, who is also who's director at Center for Planetary Health and Environment Justice at University of Minnesota. My site preceptor, Julie Kennedy, she's the Chief Experience Officer at ECU Health, North Carolina. My entire Health Innovation Leadership faculty at University of Minnesota, ECU Health, and MBSR and Eco-Awareness Project, from where I have received all my inspiration to even conceive this project. Thank you.
Wonderful. Thank you so much. What a fantastic model and such a good reminder of the importance of matching the messenger to the audience to make the most impact. So thank you for that. And next, yeah, and we'll turn it over to Beth Schenk. And Beth Schenk serves as Chief Environmental Stewardship Officer for Providence, one of the nation's largest nonprofit health systems, which has developed a robust environmental stewardship initiative. They are doing all they can to reduce greenhouse gas emissions from care delivery, building resilience in the communities they serve, and using their voice to advocate for a healthy planet. Dr. Schenk is an assistant research professor at Washington State University College of Nursing. She led the development of CHANT, Climate and Health Tool, measuring health professionals' awareness and engagement with climate change and health. CHANT has been translated to 12 languages and used in over 50 nations, and I will turn it over to you.
Thank you. And it's so nice to be here, and I'm going to ask the same question. Can you see my slides?
We can.
Okay, terrific. And I'm starting my timer. So thank you, and thank you both for your presentations, and Joe for yours earlier today. I'm excited to be with you today and always have a lot to say about this topic, which has been my life's work for about 30 years. So if I can advance my slides, this point has been well made already today. Planetary health intersects with healthcare for reasons that we've heard about. And 3 areas that I pull out all the time are climate change, biodiversity loss, and novel entities or chemicals, because these lead to health risks and healthcare contributes to these. So we might say specifically, how does healthcare contribute? You've heard a little bit about this from waste. It's an enormous amount of waste, especially in the United States. Our hospitals create 100 million pounds of waste every year. It's astonishing. We know that a good chunk of that, 8 to 10%, is food waste. Energy and water. Hospitals are often some of the highest energy users in a community, and often the largest water user. And you've seen the computer-lined halls of hospitals, and you also probably know about required air exchanges for infection prevention, as well as humidity controls. Agriculture and food. Our system alone serves 5 million meals a year, and we have opportunities to decrease the carbon intensity of that food, as well as some of the waste, and also to model healthy, local, sustainable food to the extent we can while meeting the clinical needs of patients. Chemicals, we have talked about chemicals of concern in nursing for a long time, being exposed. Nurses are considered the second most exposed profession in healthcare, janitorial staff being first, and nurses have had the highest adult onset rate of asthma amongst other professions. We now also talk about specific and direct greenhouse gas emitting chemicals, or chemicals that are greenhouse gases themselves, including those listed here. And the last piece of this model, you're going to see a model develop out of this, is transportation. That's in the US, the largest sectoral contributor of greenhouse gases, larger than buildings. It's a hard one to tackle, but we're working on that in a few different ways. And altogether, this adds up to what you've already heard today, at least in the US, that healthcare contributes 8.5% of our nation's annual greenhouse gases, and healthcare writ large is about 5% of global greenhouse gases. Our health system is pictured here. We have 54 hospitals in 7 Western states. We also have a data center in Hyderabad, India. I point that out because we work very closely with them. Those are Providence employees, 39,000 nurses, etc. And we have developed 3 pillars to drive change. The first is we act. So that is these issues: waste, energy, water, agriculture, food, chemicals, and transportation. That's our mitigation framework, because those are the key inputs of climate gases, greenhouse gases. We also work on resiliency and adaptation because we are in the throes of climate impacts right now. We had in the LA fires this last year, a year ago, we had one of our clinics burned down and another hospital almost evacuate. We've seen multiple incidences of extreme events that are impacting our health and our buildings today. And we share is our outreach, education, and advocacy framework, which I'll talk briefly about. So first, we act. We take our waste work seriously. We're making good progress. We think it's very complex. We measure 30 different streams, 30 different waste streams that we track the costs, the usage, and the carbon emissions of. And we divide it into these 3 buckets: disposed waste, that's going out the door. We're paying a lot of money for it. It's highly regulated and it's carbon intensive. Landfill, biohazardous, and hazardous. The middle section is waste that would go to the landfill, but we're pulling it out for a higher value. Compost, recycling, universal, donations, etc. Reprocessing would fall in there. And that bottom one, the green one, is what I think is the most important, because that's the waste we don't create. So we are trying to go upstream of this incredible amount of waste that comes out of healthcare to rethink. So it follows what Heather was saying in some of the work that they've been doing in the UK. And you can see our formula at the top, that our goal is to divert more than half of our waste away from landfill and hazardous streams. In other words, at least half of our waste will be in the yellow and green here. And we're making progress each year. And it's really interesting to look in the detail at the data. Energy and water, we think about this a lot with our buildings. That's the primary use of it, is building energy. We work on these in the ways that everyone works on building energy: energy efficiency, purchasing renewable electricity, trying to decarbonize, and also trying to electrify, getting off natural gas where we can. It's difficult. Our buildings are older. LED work, etc. So lots of things that are always going on, and we track that. We track it by our electricity use intensity and our thermal energy use intensity, as well as our water use intensity. Most of our sites are in drought areas, and so we pay attention to our water use and are trying to get down to 30 gallons per square foot of building space. Challenging. Our work on agriculture and food is interesting and also challenging. We focus on these 3 broad categories. One is reducing the carbon intensity of the meals that we serve. So plant forward, appropriate portion sizes, less food waste during prep and production and after meals. Also efficient kitchens, and waste, again, about avoiding the waste that we create, trying to keep whatever we do create out of the landfill because it creates greenhouse gases in terms of the methane. So composting, and we work on food packaging, which is also challenging, especially because we backslid during the pandemic. We really did. But we're crawling out of that, getting back to more reusable dishware and less unnecessary wrapping. We work on local and sustainable foods, chemical-free foods, et cetera, and you can see all this work. So our scorecard tracks many of these features so we can see it clearly and see where we need to focus and which hospitals are doing better than others. Chemicals, I've talked a little bit about the chemicals of concern. This is important to nursing. We need to protect ourselves. We need to choose products that are less chemically intensive when we can. That's a whole other topic that we could talk about for hours. And also, we've worked directly on the greenhouse gas emissions that you can see here. Our medical director is an anesthesiologist who has really led the nation's work for both desflurane and nitrous oxide, and now inhalers. So we're making good progress there. Transportation is pretty hard, I will just tell you. Our business travel, we've been able to affect because that's choices that we can make. We can have more virtual meetings. We can attend fewer conferences. We can be more efficient with going between our buildings. But we also need to do care delivery. We go to homes. We go to hospices, we go to nursing homes, et cetera. So that takes fuel. Employee commuting is an enormous piece of our fuel. And also we buy $8 billion worth of goods every year. Much of it comes from overseas. The supply chain impacts of not only transportation, but of all of our carbon emissions is enormous. It's about half of our footprint, the way we calculate. I mentioned that we track a lot of data, and we do. We track over 300 fields now to understand the usage, say gallons of water or pounds of infectious waste or number of inhalers, the cost of that, and the carbon emissions of that. And we have that back to January 2019 for all of our hospitals, and as of this year, for 1,000 clinics. It's been an amazing enterprise to try and get that automated in an efficient, verifiable, transparent way. But that's what we have now, and it's starting to be a usable database for us. It's really amazing. But most people don't like to stare at numbers. I kind of do, believe it or not. We developed this profile score, which is based on 10 elements that together paint the picture, we believe, of best practice in healthcare environmental stewardship. This kind of data, this kind of metric doesn't actually exist. It doesn't exist across the globe, though the UK has done a lot of work on it. It doesn't exist across the nation, though we have organizations like Practice Green Health that is collecting data. So we have been pretty systematic about trying to understand how would we measure so that we could know that we're meeting some element of quality. If we were going to try and describe our quality in environmental stewardship, how would we? We think we're getting close with this. It's really interesting to see. So you can see kind of off just by looking at it. On the left, the metrics are lower performance. On the right, they're higher performance from red to green. And this has really helped our leaders and our operators grasp quickly where they are. I have 1 minute left to talk about our resilience strategy. I mentioned that we're facing wildfires, heat domes, flooding, erratic winter weather as well that have people have lost their homes, we've lost buildings, we've evacuated nursing homes. You know, this is real for us in the American West. And we are focusing on our infrastructure. Are our buildings ready? On our clinical care, do we know what to do in times of extreme heat or long smoke? And are we working with our community partners to help our communities be ready? And then the last wing of our work is our advocacy, relationships and partnerships, and education. So it's been great fun to see a blossoming of interest in national leadership groups in the US and around the world. There's so much more happening than there was 10 years ago or even 5 years ago. It's a great time to be involved. We are making progress. And also, we work a lot on our internal and external education. And I didn't put the link here, but you could check out the Providence Center for Environmental Stewardship, where we offer toolkits that you can download and look at. We have a toolkit every quarter for the past 3 years. And so that's available to everybody because part of what we want to do is help move this along writ large. How are we doing? We have reduced our emissions in our hospitals by 27%. That's pretty amazing because US emissions are going up. And I'm just going to zoom down to the bottom because this does save money. That's not my key priority here, but it's nice that it does. In 2025, what we can document of saving is $46 million across our health system. So when I hear a lot of times, well, we can't afford to do that, I say, no, you can't afford not to do this. And besides this, it helps with quality outcomes, patient engagement, staff engagement, helping keep us ready to serve during these extreme events. So we're thrilled to be a part of it. I'm thrilled to work on it. And that's what I've got. So thank you.
Thank you so much. What an impressive example of what is possible. And I know you work at such a massive health system and have spent a lot of time at this. So it's just such a great inclusive example. Thank you so much to our panelists. We will now open it up for a Q&A. So first, we'll ask if our audience has any questions, and I'll stop talking for a moment. And if we don't hear from our audience, then I've got a couple of questions prepared myself that I'll pose to you all. So we'll just pause and see if we have any questions. All right. Well, feel free to drop questions in the chat if they arise, or if you have questions for one another. But I have a couple of questions that I would love to pose to the three of you, and we can just go in order that you spoke in. And I'd love to have each of you answer from your perspective. So first, across hospital and outpatient settings, where are you seeing the greatest opportunity to integrate planetary health into core care delivery? Really thinking about this not being an add-on, but being part of quality, safety, and patient outcomes. So we'll start with Heather.
Yeah, I don't want to rehash or basically repeat, but I think just in terms of your question there, I think as nurses, and maybe I'm speaking slightly biased as an ICU nurse in acute and critical care settings, but I think those what Elizabeth was talking about on that bottom bit, that I forget what you called it, but you had that bar chart that where what is possible to avoid, and I think there's also such an ethical tension that comes from working in a space where you're throwing things out that you know is perfectly good or didn't need to be thrown out and all of that. So I think for me, it's really looking for those quick wins and those easy wins that can have really big impact, but just a small amount of change and just simple things, particularly things around medicines, that not overstocking at the bed space, not, looking at prescriptions when everybody's busy. Rounds go on and then somebody's on the same medication for days because it's harder to stop doing something than it is to introduce something. So I think just having that mindset where you're always thinking about, less is more and what do we need to do today, but also what do we not need to do today, and being very intentional about not doing things. And I think a lot of sustainability comes about from either avoiding or particularly if I use some intensive care examples, when somebody first comes in, maybe they're really sick, they need a lot of sedation, they need a lot of other drugs, they're not being fully fed yet, but why are we continuing on the same protocols 3-4 days later as they're getting better? And actually they don't need a lot of that support. And it's better for patients if they're less sedated, less ventilation, getting out of bed, just good old fashioned, get people up out of bed and see families, get them outside, and guess what? They do better. So I think it's looking for those types of opportunities that doesn't necessarily even need to feel like it's a planetary health intention, but has so much impact on reducing waste. And that whole kind of, when I do this in teaching, I usually call it which I know other people have written on this and stuff, but just calling it the Goldilocks principle, not too much and not too little, but just right. And the other phrase I really love, which I didn't come up with, I can't remember who first said this, I think I saw on a blog somewhere, was Zen-tensivism, that if we all just be a little bit Zen in our intensive care world, you are more sustainable. So taking a moment to just stop and think and being very intentional about what we're doing, but also being very intentional about what we're not doing. And maybe it draws from your mindfulness, Kamala, be very mindful of our work. And because we're so protocolized in our care and, we're all busy and it's, like hamsters in the wheel, just going round and round on a 12-hour shift, and just taking a moment just to think, what should I be doing today, but also what can we stop doing? Just some thoughts and reflections there.
Thanks so much. Those are really fabulous insights. I think we often think about what we can do and maybe not so much about what we can not do. So that's a fantastic insight. I'll hand it over to you, Kamala. And I did put the question in the chat in case any be referenced.
Thank you, Heather. 100% agree. Like I think we just need people to slow down, think for a moment, and reflect. Okay, what is not doing out of their motor functioning, and then wasting a lot of things. But if they just take a time to reflect and think, I think there is opportunity everywhere, everywhere. From cafeterias to intensive care units, peri-operative environment, everywhere. For example, I would like to talk about a peri-operative environmental setting, getting rid of dysphoria just happened in our hospital, and it didn't take much effort. So we have so much science already to say what works and what doesn't. At least if we can just like try implementing them at a faster pace, and that works. That saves a lot. And then, for example, cafeterias, not just because food is such a bridge between health and planetary health and human health, everything, reducing not just the waste, but how are we sourcing our food? And then also the containers that we use. I was doing a research paper on this. So food contact material, they use a substance like PFA to make it so that the water and grease doesn't get into them, and they're highly toxic. They're hormone disruptors. So can we like ban everything like that, like coffee cups, small things, but that we use so much of them every day. So I think there is opportunity everywhere if you just everybody doesn't need to like sit and reflect. and be conscious of our choices.
I love that. Thank you so much. As Heather said, I think we really do need to draw from the mindfulness approach. So thank you for that reminder. And I'll hand it over to you, Beth.
We have a phrase that we say, which has two parts. And the first part is data are the backbone of our initiative, because in healthcare, especially moving at scale, you can't get very far unless you can really defend your decisions and the impacts. But the second half of our phrase is, and engagement is the secret sauce. So what is engagement? It's what you all are talking about. And it is inviting and including and getting people involved and on board and wanting to contribute and asking them about their own wisdom for doing so. Because you know who knows how to do this? It's the clinical practitioners. I mean, healthcare is about clinical care delivery, including mental health and physical health and others. But it's the experts who know how to do this. So we need to be asking them, which we do. I mean, how could our small team know everything about healthcare? But the people in healthcare know about that, especially if we help them to ask questions differently about their practice and help them to measure their results and help them to find some resources where necessary. So I think that's probably the greatest opportunity. You know what also is, we're on the verge. We've really just started to do more with our clinicians, and that's because for about 5 years, you all recall, we were under the throes of the pandemic, either the pandemic itself or the recovery, which has been tough. And so it's just emerging now as a time that we can really start to reach out, in Providence anyway, to our different clinical teams. And it's great because so many are so interested, but they don't always know where to start. And we can't answer the questions. So I was just jotting down some questions that I have for our experts who are our clinicians. What are the best clinical pathways? What can we understand about clinical choices that drive less consumption, drive less unnecessary testing, drive less, greenhouse gases, et cetera? What can we do about this very present tension between consumption and infection prevention? Now, causing an infection is unacceptable. And an infection is much more resource intensive than preventing infection. At the same time, we probably have to question our zero risk tolerance mentality, because that's not realistic. And we can make wise and informed choices that look at really the whole picture of those impacts. And then also purchasing, as I've talked about before, most of the stuff we purchase care, who makes purchasing decisions? In the end, it's the clinicians. Many clinicians feel like they have no control over that it's the health system, et cetera. The value analysis teams that have to go through to make those decisions have to go through clinical eyes. They have to be approved by chief nursing officers or by medical officers or by surgeons groups or whatever. So this is a place where we really need clinicians to understand those impacts and to be able to get involved. So I think there's lots and lots of greatest opportunities. And I would just add that always we need to be doing messaging, making the case, and reminding people of what you all have talked about the ethical alignment that, especially, in the professions that are committed to care and to health, this is very much a part of what we really must do. And I see it happening. So I'm pleased about it.
Yeah, thank you so much for that. And that's such a good segue into my second and last question, which you may have answered some of. That is okay. So we'll start with you again, Heather. And the question is, what has been most effective in activating clinicians and staff? So not just to understand sustainability and planetary health, but to actually step into a leadership role and really lead and sustain change within their organization.
I'm so glad you brought up the point about sustaining change, because I've seen a lot of fantastic projects, mainly done because people are eco warriors and they're spending their own time, they're not being paid, they're finding a way, they move on, and all of that work goes. So I think a real question is, how do we sustain the sustainability and do that system change you talk about so it doesn't rely on people? Because if it relies on the volunteer eco champion, the green ward link person, or whatever, an organization, a self-declared person like me that just bosses around until things happen. And then people tell you can't, and you're like, oh, okay, tell me I can't, I'll find another way. And then you call it something else, and then it's okay to do it because you've rebranded it as something else. But that's great as long as those people with enthusiasm are there. And I think, yeah, where I've seen the best things done, or like the longest lasting, and you sustain the sustainability, is when there really is that cultural shift, and where it's more than just one person and there's teams of people. And I think teamwork and green teams are really instrumental in departmental change. And maybe I'm going to be a bit biased speaking from an educator point of view, but I think education does have a real role in around, and I know there's been other sessions around embedding this into nursing education. And I was just talking to some students recently, and they are so passionate. And so this is so much a part of their way of being. They almost didn't understand the question around, oh, how can we embed this into nursing education? Like, oh, isn't this already there? Isn't this part of, how we're going to function as nurses, was the kind of general vibe of the question. And so I think using the power of education and some fantastic projects where students, Beth, you talked about data, and everybody's busy. How do you get an audit done? How do you get a data collection? There's always a student looking for something. There's BSc students, there's MSc students, there's PhD students. There's oftentimes people need to do something and they're not quite sure what to do. And it doesn't even have to be a full sustainability project. It could just be, oh, can we just have a planetary health lens on the thing that you're doing it already, or you're doing a literature review on something, or you're going to do an audit on something. And and it's being efficient in that use of time. But yeah, I think just in terms of the question, those are the thoughts that are off the top of my head. And just, I think that's really, really important about that, sustaining the sustainability, particularly because years ago, I remember there was an ICU in Kent who'd done some fantastic work, and they presented it at our share conference, and had, reduced the waste, and it was all great. And a couple of years later, I ran into somebody who was from that hospital, and I said, oh, I heard the ICU is doing some great stuff. And they're like, oh yeah, that person left and the manager changed and the bins got moved back and nobody's doing anything anymore. And so I think the points that Beth was saying about this is about the entire thing. It starts in procurement, and then we use the stuff and we have waste management, but often clinical nurses have been very disjointed from that buying and the storage and then the waste piece of it, and having much more of a conversation. And I know in the UK, in some places they've got procurement nurses now. We're getting nurses involved with waste management teams, so that there's the people that are doing the job are much more linked in with those clinical pieces.
That's really fantastic. Thank you so much for sharing those insights. And I'll hand it over to you, Kamala, if you would like to answer in just a minute or so, that would be great.
Thank you. I also agree that to have it really sustainable, it has to be within their organizational culture, leadership culture, that it has to be value driven. Anything to be sustainable has to be driven by value. So I don't have an exact answer. This could be our best hanging, like low-hanging fruit, but I think if they're driven by this mindset, okay, whatever we do, we have planet at the center of our table, that will help, I think.
Great. Thank you so much. And Beth, do you have anything else you'd like to add?
Well, to that particular question, we call this hardwiring, and it's just what you said. Get it built into how we do business. It's not an add-on. It's not a side hustle, as they say. It doesn't depend on an individual. It's because of the organizational commitment. And I just wrote down 5 examples. We had an executive pay package linked to our environmental stewardship progress. That was huge. We have an environmentally preferred purchasing policy that is having more and more impact every year. Our leadership hires, this is an included element of an expectation of people who come in now. Our recruitment website also advertises, or not advertises, but shares this information because we want to attract people who are interested. And we include it in many, but not all, new caregiver orientations. We try and track the number of examples of hardwiring each year so that we can continue to move this forward, because it's exactly right. This is a transition of how we do things. It's not just something that a bunch of people are interested in. So thank you.
Thank you so much. That's a really great and inspiring place to leave us with some actionable strategies for that really deeply embedded systems change. So I want to thank you all for joining us today and for your fabulous talks. This is really a great way to end the day, and thank you for all of the wonderful work that you do. Take care.